detailed and substantive. They are introduced on an annual basis. You can see the figures on all the regions. Similarly, the program has full-fledged data on the countries where infections occur. We can see the growth in the number of new patients, in contrast to many regions of the world where the epidemic is currently being controlled, but we are aware of our situation. Over the last years, we have decreased the number of new challenges of the new HIV cases. But unfortunately, the situation is totally different in other countries. In ECA, we can see the 275% growth. It is either super epidemic or the false figures. Here we can see the prevalence of the HIV infection in our country. My presentation will then follow, and then you'll listen to Professor Nechayeva's figures, who will present the recent data. The situation in Ural in Siberia is sorrowful. As for the situation in the USA, we can see the territories, the urban quarters, which have great differences, drastic differences, which are affected by this disease. Still, these figures in some regions of the USA are tremendous. They're extremely high. And the figures in the ROW also make us fear. We can see two kinds of statistics. The data of the Rospotrebnadzor and the Scientific Epidemiological Center's data. This data is included in the total statistics. We can see the disparity, the large gap. Vasily Kravchenko will dwell upon the figures. They are analyzed in a detailed way. Here you can see the situation in Moscow. We're aware of the number of all the patients. We work with them on an annual basis. How many patients are there in Moscow in total? We identified 1,3,500 patients. Some of them died. Some of them died, and some of them died, but we are not aware of it. They haven't referred to our center for over 7 years. We work with civil registers. Some of them do not report to us. Now we're actively searching for these people. Maybe they are buried in other regions of our country, but in the past we couldn't manage to identify them. The data is transmitted to us, and we can see statistics on the people who died of this infection. It is accurate, and it is related to certain regions. These cases were identified in Moscow. Still, they are still here. Some of them came here from Moscow in order to receive medical care. We're happy that people from all over the country come here in order to be treated. But this doesn't mean that all of them live in Moscow and that Moscow is their place of residence. How many patients are actually here in Moscow? Some of them are under our regular medical checkup. We have medical reports. We can understand how many people are there in Moscow, where their address, their places of residence. Let us review this data once again. In 2019, the data presented in this report have increased 3 to 6 times compared to the real statistics. It's not the only figure which has changed. 6,000 people moved home in order to report for them, and 12 people were added. That is one of the most explicit sources of these data gaps. And we will also dwell upon it. Here we can see the new cases in Russia and the decline in the number of new patients associated with intensive growth of tests for HIV. Our regions have conducted this work. The Ministry of Health of the RF has carried out lots of tests for HIV. We covered lots of regions and created the favorable environment for those who have to be tested for HIV. And now we go further. I hope that we will include the professional community in the HIV programs for checkups. We are also streamlining the economic aspect of this work. We can see the following strategy. The tests for HIV are objective, and we did defend this strategy. Now it is normal for all the countries, and then we will include the tests in the checkup program. It will be our next step. It's rather substantive. The number of the detected patients has decreased drastically, and there is a link between the number of these patients and this study. We could see some data on the analysis of mass screening for detection of them. We can see lots of indicators and formulas. We know that these high levels of screening allow us not to impact the number of new patients. We detect those who have to be detected this year. We can see the detectability this year. It does not depend on the number of studies. It shows the trends, the declining trends, and it is our key indicator. The number of studies decreases, whereas the number of people diagnosed increased. This confirms our thesis. Still, we haven't carried out the scientific work. We haven't published it in the articles, but now we have this data available and we can show the statistics. The number of studies and the number of tests for HIV has decreased drastically due to the COVID pandemic. It decreased by 50%. The number of the examined people decreased by 50% in all over the world, according to the statistics data of different countries and monitoring centers. The key points are represented on this slide. We have lots of people examined in Europe. And how does this decline impact the situation? Despite the events of this year, the situation has decreased the number of tests for HIV infection in a minimal fashion compared to other countries. Evidently, over 90% of our patients are aware of their status. It is the vital indicator for our country, and it has been fulfilled long ago. Here is the register of the patients with HIV infection. It's important work of the previous strategy, which was implemented in our country in 2011. We decided not to carry out such register for several reasons. It was the political will of those who decided to carry out it, and they did carry out it. It's respectful. It's a unique tool which allows us to work with this data in a comprehensive way. I mean the data on the patients in terms of epidemiology and the needs of the patients who have to be diagnosed and treated. We'll have a particular presentation on this issue. According to the register, we face some challenges. We understand that this database is not like EMIS, where everything is digitized and there is a barcode on each test tube, and then the data is included in the medical records, and everyone may scrutinize it, and everyone may control digitized healthcare. Moscow is an absolute leader in this area, but now this register also gives us such opportunities. We live in an immense country. We are not always satisfied with the data transfer, and not everything can be implemented in our country in the full scale. And we don't have any manual work. Still, this database contributes to statistics this year. The register forms the 61st form. It is the crucial landmark. We have the resources reflecting the statistics of our country. Another chief aspect is coverage. It is questionable. Still, we can see the coverage rates over the last years. The Ministry of Health has conducted great work, as well as the territory centers of combating the HIV infection there are 200,000 patients who are now receiving the ARVT drugs in our country. We are leaders in terms of enhancing the coverage under harsh conditions.
And another thing to mention, and another challenge for our patients, as opposed to Eastern Europe and Western Europe, is that Russia has become the hostage for drug abuse. And HIV is an indicator of this particular problem. And the cohort of diseased are those who were HIV infected upon the drug injection. And the question arises how the treatment needs to be organized, the commitment to that treatment, the regimen for that treatment, and they might not be necessarily HIV infected and also have the C hepatitis. And we in our centers have to cure co-infection. And actually, we are keen on the elimination of hepatitis C, and that is an outstanding program, and it is attainable with due regard to the expertise we have acquired in combating HIV infection. And for a number of years, we've been handling the mass scale diagnostics with the titles of viruses and individual selection of treatment for each patient. And the first here shows the scheme of and recommendations for treatment upon the WHO practices and recommendations of the United States. And the scheme of the first line looks somewhat different as opposed to the current one in Russia. And we have the 5-year system, the based treatment, and that is a full-fledged scheme for the treatment of the first-line patients. And of course, we need some TDF, and if we have some kidneys problems, we have to add some other things. And that is why the scheme is patient-centered, the scheme of treatment, especially when we are on the start. And we have to start from one scheme, then speed up, and then somehow adjust the new scheme of treatment. And already we had some applications arriving with the new procedures and procedures which are individual ones for patients. COVID is an absolute disruptive factor for us. And it affected to a large extent our reality. And now we have to combat the new infection named COVID. And we taught our doctors of various specialities to treat this infection, pneumonia, and render medical aid to very severe cases. And our labs have become the center for medical examination of various patients. And it becomes quite clear that the challenge we are facing is a real disaster for this country. But our centers managed to survive, and the quality of medical assistance rendered to HIV patients is still the same. It's being maintained, and all the drugs are to be prescribed, all the checkups are necessitated, and each region has its own efficient system for HIV patients, and the system of treatment in particular. HIV/AIDS posed immediately a question as how to combine the treatment of the two diseases, whether these patients are conducive to SARS-2, and pretty soon the scientific community formulated the premise as how to deal with that diseased patients, and already this survey was published based on the Madrid cohort data, and they had a broad-based survey at this point of time at the very start of the pandemic. And what is the actual reality for these patients? Let me remind you that our center opened the hotline, and we have the collectors as one of the drug to treat SARS-2. And a year ago, that was one of the most efficient medications for COVID-19, and the HIV medication has become in a high demand, and we had a very high load on the center a year ago. And on a parallel basis, we also surveyed the impact of SARS on HIV/AIDS. And accordingly, the last survey demonstrated the full-fledged picture and how those infections are influencing one another, how to treat those infections. We know the gravity of consequences if the people have low CD, that is 4, and we have some kind of standalone surveys made dedicated to race and to other infections may also influence the process. Quite a substantial database has been have been collected, and we followed very interesting reports of our colleagues at this forum, and I believe that we know what we're talking about today. We had some kind of unexpected articles to be published in some specific journals. Though the internet data has some other facts to expose which are not in line as to what is being discussed at this forum. Probably internet is the one thing, but the specialized journal has its own takeaways with some very authoritative and competent conclusions. Vaccine for HIV. A year ago, we discussed the regimen for SARS vaccine relatively to HIV infected. We have quite a detailed report provided on that score, and absolutely all the vaccines are available for HIV/AIDS, and we may also have a specific calendar for vaccines and vaccination of HIV patients, and which vaccines are preferable now and could be administered in the HIV center. We knew that Sputnik V was an absolutely safe vaccine. That is the most safe model of vaccines, and it gives a chance to our centers to administer those vaccines quite successfully. And the only detail to mention that if the patient has a CD lower than 200, they have to be somewhat cautious to vaccine. Our colleagues in the Chumakov's Institute have another type of vaccine, and we have the Moderna and Pfizer data, and we also have other data. Thus, we may on the vaccine, and we may insistently recommend to our patients to get vaccinated upon the consultancy with the doctor, and this is a real cornerstone stage of our interaction with the patients. And you would look through the algorithms of vaccination of adults and those other HIV infected, and if it is necessary, some new session would be organized on that score. What is the public strategy for 2030, the government strategy? And it has become a definitive step forward for responding onto the infection. And we are now building up the R&D block, and we have some indicators embedded into that strategy, and they are going to be implemented further. And the minimization of the new HIV cases, full-fledged assistance, medical assistance, and other strategies are embedded here, and we are really keen on the R&D solutions at the global level, at the level of partnerships. And now we have some temporary plans for the implementation of the current strategy, and they look quite serious. And in each region, we have plans of actions with regard to the dissemination of infection, and international cooperation in that area becomes a predominating factor. And I've mentioned already that SARS-2 opened up a new epoch for people focused on viruses. And one of our colleagues, Mr. Liederman, published a very interesting analysis for various strains on HIV, and we were one of the first to start using these new findings based and we do it on the basis of our hospitals. And our French colleagues published a preprint for 50 patients. At this point of time, we already had 200 patients of that sort, and we also had placebo, and we rendered substantial assistance to our patients, and we've managed to publish the article in various journals in a short period of time. And so this article saw the light, and this international expertise of ours has become indispensable. And we started monitoring the process, and at a global level discuss the new strategy for treatment and sorry, for tautology. We're talking about the new infections. So today, we nowadays have the International Expert Council for National Virological Association, and originally it was the partner of the network, and these or that reports of our colleagues were dedicated to these to the issues of viruses. And Robert Gum was the one to be the head of these particular meetings. And we had a chance to communicate with our partners from Japan and other countries. And now we are facing some new challenges, such as SARS-CoV-2, and we understand that such alliances should be open and transparent, and thus we discussed some joint projects and joint findings, and vaccine generation on HIV infection was a focal point. And 7 years ago, when our colleagues came here to Moscow, and one of my colleagues came here. He was at the head of the global program for the HIV vaccine in Bill Gates' office. And we discussed it all together with the journalists, and we spoke about the efficient vaccine to be originated. And we had a hope that President Clinton will see the light and will see the vaccine to originate. He was the one to put the first brick in the foundation of the building for HIV vaccine. And we do quite a lot of work and with contributions, and actually the vaccine will be tested on the third phase. And Anthony Fau is the one whom we've been negotiating on that score. There are quite a number of other vaccines which are being developed and they're being tested. And I do hope that such breakthrough will soon be visible. And already we have very good developments for cancer diseased people using this targeted configurations. And already we see that the Russian vaccine needs to be created. And this is a part of our new strategy.
Oh.
Yes, I exceeded the time limit. Thank you very much. And now let us move on to the following presentation of our session. Let me introduce Olga Nechayeva, head of the Federal Center for Monitoring Combating Tuberculosis in the Russian Federation. The professor, we will keep discussing the topical statistical issues. That's not the name of the presentation, but we will actually dwell upon it. Okay, thank you. Dear colleagues, let me say a few words about the indicator calculations. This year we amended them, and the 61 first form was represented by different departments, and then they will be united by Rosstat, and we will get the total parameters for the RF. We can have the same, these following factors, and we have complete factors, and not all of them are related to the number of patients diagnosed. As for the calculation of the parameters, in accordance with the federal legislation, they are calculated by Form 61, including prevalence and morbidity. As for mortality, it is the Rosstat data. This indicator is aggregated. It encompasses the whole system of healthcare. As for mortality, I've represented preliminary data. It's not based on calculation. We can see the data of Rosstat over 2019-2020. I calculate these parameters for each pathology, including tuberculosis, and the difference in them is at least 1/10, or the difference is insignificant, and the data is actual. What has actually happened? Last year, we organized a similar conference, and I said that the stabilization in the HIV infection is being observed nowadays. It has been happening for 3 to 4 years. This year, the decline in morbidity and mortality is drastic. And this is not only related to HIV infection, but also to tuberculosis and other infectious diseases. And the reasons for this decline is the absence of contacts. The ones who were in the risk group in morbidity and mortality were at home. The contacts were limited over more than 6 months of the year. There are some countries which were highly affected in by HIV, but the foreigners from these countries didn't arrive here. Thus, there was no propagation of HIV infection. And the third reason is the decline in the tests for HIV antibodies. It reduced by 25%. It is the highest indicator in the world. Maybe it was believed that we had not diagnosed some data, but still there is some some professional there's a professional examination for HIV infection. When people come to a new workplace, they are tested for HIV by fluorography of thorax, and the antibodies for HIV may also be diagnosed, and some of them are referred to inpatient departments, or some people came to a new workplace and they wanted to be employed, but we cannot claim that we have underestimated the number of these cases. We can see the decline in both morbidity and mortality, and the rate is identical, which testifies to the decrease in these indicators. As for the gender, the rate is similar, namely the decline in morbidity in both men and women. Over the last years, we've registered the dramatic decrease in the morbidity of children. It has declined by 2.5 times over a few years. Today, we register stabilization of HIV infection parameters. We're not aware of the future situation in the post-COVID era. The ones who were not diagnosed last year will be diagnosed this year. There are so many stages when people are tested for HIV antibodies. There is no data on gender mortality for 2020, but I believe that this difference will be insignificant compared to 2019. The core age for morbidity is 29 years old, but in the past, this age was 25, 34 years old, and this year and last year, the peak was 35, 44 years old among women. As for men, you can see the same peak, 45 to 54 years. As for morbidity, mortality, 25 to 34, 50, 55, 35, 44, and we can also see the peak for 35, 44. Who are our patients? Here is the structure of the morbidity. 90% counts for our patients of the healthcare system. In the red, you can see the red color, which signifies the prisons. Last year, we saw the decline in the professional examination coverage. 90% of the patients diagnosed in prisons were diagnosed in prisons for the first 3 days. Nowadays, we have to work on the groups of the social risks, which are known nowadays. Still, we do not carry out sufficient work with them. Who can suffer from these diseases? It's open secret that Ural, Siberia, northwestern, and some other regions are affected by it, and the gap is dramatic. It is at least 2.5 times. We can see the territories of the first decade of the years 2000, and people suffered from drug addiction. I come from Yekaterinburg, and I observed the situation when the police also dealt with drugs. And then I moved to Moscow, and I saw that the central television showed the ones who were diagnosed. Siberia and Ural were affected by this disease. There are lots of infected patients in these regions. Some of them haven't still been diagnosed, and some of them will be diagnosed in the near future. The women gave birth to babies in 2020, represented here. And many of them were tested for HIV infection. And this indicator is unparalleled of the world, but as for our country, it is included in the standards. As far as I know, few women are tested for HIV infection because it depends on their willingness. If they are in the labor houses without being tested, they will be tested to anti-HIV antibodies. 0.7% of these women are seropositive. You can see the great gap between Ural, Siberia, Privolzhia, and northwestern regions. These women demonstrate positive results for HIV antibodies over the last 4 years. 0.9% of all the babies who were born in Russia were delivered by HIV-infected women. That's the most substantive problem we face right now. All the delivery clinics are focused on HIV antibodies according to our standards. Pregnant women are tested for HIV many times, and then these tests are carried out in the labor hospitals as well. And we also focus on chemo prevention, and the level of chemo prevention is not that high. As for pregnant women, we can see those who interrupted the pregnancy, made the abortion, and there is also 98%. I cannot say that the prevention scheme is satisfactory, and some indicators emerged this year. We can now calculate the prenatal risk of infection. It was first registered in Form 21. We can now register which way the patient was infected. We can now calculate the number of confirmations of HIV infection in babies who were born over the first 2 months. I cannot understand any other way of these children. They were not diagnosed properly. Over 2 months, those who are diagnosed with HIV infection, 2/3 are diagnosed on the second or the third month. In some cases, they were diagnosed in 30–40% of cases. They all comply with standards. They have the necessary equipment. They know how they have to deal with these children. Why do they actually diagnose them so late? Some women may leave the labor houses without being examined. Thus, children may suffer from it. And the experts have to dwell upon this work. I've represented the data on all the territories. Hope that Mr. Mazus will understand in which territories the HIV infection is diagnosed too late in children. The lower chart reflects the situation in the territories, and the key pathways are the sexual pathway, the parenteral way, and less than a third accounts for the parenteral pathway. And so the contingency, we can see all the territories apart from the northwestern regions. This late diagnosis has few reasons. Some people diagnose the patients with HIV who were infected in the parental way too late, we have to assess the situation in the northwestern region in order to understand why they are diagnosed so late. The sexual pathway is the major one, and we understand that the most widespread one is parental one. And the ones who were infected in the parental way may now transmit this disease in the sexual pathway. Thus, we need joint efforts in order to combat this infection. Another problem is tuberculosis. One of the key causes of death of HIV infection is tuberculosis. We're aware of it. But over the last years, the proportion in tuberculosis is decreasing because we are cautious about chemo prevention. It has been introduced since 2014. Now we understand that we do need chemo prevention, and this resulted in morbidity. The morbidity of HIV-infected people started diminishing in 2016 when people started carrying out chemo prevention of tuberculosis. Nowadays, we have a lot of HIV-infected patients. I've divided the whole population into the infected people and the people who are not infected. We understand that the morbidity of the HIV-infected people is 60 times higher. I mean, those who have fewer than 200 cells, and in this case, the indicators would be 150 times higher. Some of the works were related to asymptomatic cases. The number has increased almost 60 times. If we hadn't had the HIV infection, the morbidity would have been 21. And the best indicator of the Soviet era was 34, when the HIV infection did not exist. The prevalence and morbidity are normally affected by HIV infection. They are primarily affected by HIV infection. Concurrently, look, the HIV is decreasing now. In the past, I dwelled upon the stabilization, and now we can see the number of these patients, and our medical care resulted in the situation in a positive way. We should not only combat tuberculosis, but we also need different medical services and social services. What are the reasons for that? We know that the combination of tuberculosis and HIV infection is common in the regions where HIV prevails, such as Ural, Siberia, Privolzhia, and the northwestern region. These regions have the high rates of mortality. In the cases when people die of HIV infection, and more people die of the combination of HIV infection and tuberculosis than of tuberculosis. There are much more patients suffering from tuberculosis in Siberia and Ural. And HIV infection is considered to be the key mortality reason. The HIV infection is the major risk factor on tuberculosis progression. On the other hand, if the HIV-infected people could not suffer from tuberculosis, they wouldn't die of tuberculosis. And the situation with HIV infected people depends on the situation of tuberculosis morbidity in the region. As for the leading regions, the morbidity of HIV-infected people is much higher than the mortality in the central region and in the northwestern regions. It is approximately 2% of the population in these regions, but it is a little bit much higher than 0.5% in the central region. On the one hand, the HIV infection impacts tuberculosis, the morbidity and the prevalence. On the other hand, the tuberculosis impacts the mortality of HIV infection. And we may leave this vicious circle thanks to joint efforts. There are some slides on this strategy. This strategy will be added by the plan of events, of the plan of activities, and it will accurately stipulate our future steps. These criteria differ from the criteria set by the previous strategy. Here, unparalleled. Today I focused on indicators. Here are the targets of the governmental strategy till 2030. Here you can see the number of new cases. In contrast to anti-tuberculosis services, the AIDS centers were not responsible for epidemiological indicators. They did not discuss either morbidity or mortality, and now these AIDS centers are responsible for mortality and morbidity, like physiatrists who are responsible for morbidity and mortality. The medical examination rates will also augment. For this reason, we'll have to amend the legal framework, and we'll also focus on the transmission of HIV infection from mothers to children. Nowadays, apart from this strategy, we have the ruling 199, and we carry out monitoring within this ruling. On the 1st of September 2021, the new sanitary rules aimed at prevention of AIDS and hepatitis will come into effect. Over the first 15 minutes, the President dwelt upon healthcare. So he mentioned the COVID-19, and then he said that our cardiovascular diseases will be the focus of our attention, as well as the situation with cancer. And he also said that we have to focus on hepatitis C. Nowadays, there will be some changes in our structure. Thank you for your attention.
Thank you so much. After my long presentation, I didn't give the floor to our audience for Q&A. Yes, I talked in much detail, and maybe we have some questions from the audience, because further on I would like to organize the general discussion. Dear colleagues, the floor is yours, and you may put any kind of question to myself and to our second speaker. Thank you. Thank you so much for your weighty contribution, that you came here, found some time, and I would like to send my best regards from Khabarovsk. Thank you once again. Vasily Ivanovich Kharchenko, the head of the Epidemiological Clinic and Epidemiological Center for AIDS, is going to talk about statistics. Vasily Ivanovich is ready, and they are in our office, located in our office in Moscow, and they, on a permanent basis, used to stay there and communicate with different countries. And we were supposed to organize some kind of a hub. It needs to be organized in a proper way, and we have to tune in. And we had some kind of a hub in the Far East, in the Urals, and in order to communicate with the USA, with China. And it was hard to do with the it was very hard to communicate sometimes with Moscow. So Vasily Ivanovich, thank you, Alexey Israelevich. All the activities opposing HIV infection based on the ruling of number 21 for the city of Moscow. We do not see your presentation, dear colleagues. Will you please download the presentation? Dear colleagues, your presentation is not visible. The presentation is on. You have to put it on a screen for the demonstration. We cannot see you. Push F5, yes, to make a full screen. There will be a full screen. It's not a full screen. Please click the demonstration. We have to find the active window for presentation, F5 or demonstration. That's it. Vasily Ivanovich, are you with us? Vasily Ivanovich, please. Now we have a sound. Okay, so the capital of Russia has quite a number of peculiarities affecting the epidemiological process. And really, we have to actually affect this particular situation. We have quite a diversified population and a number of groups of marginal nature and deviational behavior. Again, a problem. And the HIV infection for megapolis is rooted into the pendulum-based type of migration and employment. Therefore, we have the augmentation of HIV infected in Moscow. Labs and the system of lab diagnostics seems to be a predominating one. They're of different organizational style and type of ownership. And so we have screening lab, we have reference diagnostics lab, and also we have some commercial labs. The biomaterials and there may be taken in other regions. And further on in Moscow, it is being screened. And also we have some factors for the objectiveness of the epidemiological processes. And the commercial laboratory or regional laboratory may present not a verified list of surveyed persons, individuals, and foreign-based employees, and sometimes the address is not correct, and sometimes the forms are not the forms which were taken are not very proper, and the terminology implied could be different, and forms and templates could be different. At least 4 of them were valid, and that is why we have some errors committed in the city of Moscow, and sometimes statistics becomes not very verified, and thus people may manipulate this data. And the distortion of statistics are vividly seen in the form number 4. And it was enacted last year, and they changed completely the structure of this template, well, inserted some new indicators. The table was also inserted, and the groups look somewhat different. And up to June 2020, medical labs didn't work with this form, but Rospotrebnadzor insisted on including this data into the standard template, and therefore public statistics data are distorted due to that fact. And the scenario for duplicating the data on HIV infection is another challenge. And thus, Dni Epidemiology of Rospotrebnadzor could be also wrong, and we have some digital data upon the form 4, but personal data could not be provided from the form 0510 of the Moscow Center for AIDS. It looks somewhat different, and they presented statistics for the region, and initially it is not visible who the people are and where do they come from, thus entailing the duplication of this data and just shaping up just in the wrong profile for the statistics in the region. We try to optimize the entire process for HIV testing, and we stimulate the population for testing, and we have to organize testing for foreign-based citizens. And over the past 10 years, on an annual basis, we have the growth of HIV infection cases, but some indicators go down due to the pandemic and due to the lockdown and more active procedures of the medical entities. And nowadays we have 135,000 HIV infected. And we have Muscovites, and less than 50% are Muscovites, the permanent residents. But over the past time, the statistics registered less than 30% of permanent residents having HIV. And we have this invariable trend for the downsizing of this parameter. And the prevalence of HIV at the level of pregnant women by 8 times lower than other statistics. As for generalized statistics, and the Moscow city shows less number of HIV infected versus other capitals, and this is the picture is uneven. In the east and northeast, we have this prevalence of disease to a large extent. As to the dynamics of detection of HIV, it is more extrapolated to the migrants. And also, we have now lower indicators for HIV infections for Moscow. In the Central Federal Okrug, the level of such a disease is the lowest. Males are infected higher and more as opposed to women, and as of 1987 statistics and for 2020. And the average growth for positive tests is much higher than that of females. For men, it's more than 60%, and over the past 12 years, for women, we have this augmentation with a 0. And the dynamics identified in the mid 20th century was relying on the effect of scissors, and people over 35 constitute 80% of HIV infected. Over the past 12 years, we witnessed the obvious trend for Moscow, for the younger generation, having some new statistics. And so the vertical transmission for HIV is less than 1%. Also, homosexual dynamics goes ahead of the intravenal dynamics. And as to men, the HIV have a high statistics for homosexuals, and in 2020 it's a predominating factor. The cumulative indicator for HIV is 54.014. And we have the documents verifying this mere fact. About 14,000 HIV infected died. As to the epidemiological surveillance, within certain years, we had various types of surveys provided, and HIV infections are embedded in the as a part of the sexual transmitted diseases, also drug abuse, and also anal sexual contacts for men and for women, and the frequency of active anal contacts is growing from the part of HIV infected, and they really incur certain risks for their sexual partners. And actually, the contraception here is not applied. And as to the classical condoms, especially for anal contacts, it's not a very regular practice. But actually, the preventive measures are not always undertaken. And the only efficient measure for preventing the HIV infection tends to be the socially safe model of the behavior of the population. And we may exclude some actions in order to minimize the number of vulnerable layers.
We have provided absolute access of the population to anonymous tests, which is free of charge. We control the epidemiological situation and the decline in the new HIV infection cases in the residents of the big city. We also see the transmission of HIV infection from the mother to child is extremely low for the modern healthcare system. Thank you very much for your attention. Thank you. Thank you. Vasily didn't cover the prevention prior to the contact. We lack this data. It is a key step in the prevention of HIV infection. The prevention prior to the contact has to be the major tool for HIV infection prevention when sexual contacts with unknown partners with unknown HIV status are risky. We have to review various opportunities, people for complete access to these medicinal products. We have this potential in our country. Each doctor of each center may provide the corresponding consultation, focusing on the algorithms of use all over the world. Still, there is no consensus in the world, like in San Francisco, Paris, or London, in terms of purchasing these drugs. And there are some corresponding discussions in our country. We do need this information, these sources of information. Maybe medical insurances will be introduced, but no one is aware of it. It's not the issue of healthcare, it's the issue of economists and those who make decisions on allocation of target funds for this work. Now we move on to the following presentation. Natalia Litvinova, Grigory Kaminsky are our speakers. Today they are the leading moderators. They tackle the Federal Register, they elaborate on it, they track the operators' work. The Federal Register works in a certain way at the level of the regions, and it's their responsibility. They have plans on the modernization of the register. There are some feasibility studies in this regard, and we'll try to switch on the application for the doctor's convenience. Now the work of the register is full-fledged. We have created this resource. We just should minimize the time limits and create the automated entry models. Natalia, can you hear us? Yes, I can hear you. Sorry for technical problems. Okay. Dear colleagues, technical service, what's happening? Whereas you are fixing the camera, we may listen to the next speaker. So we should listen to Oleg. I know that you have such a hot period, just come from Central Asia. Thank you for Far Eastern greetings. We'll listen to a presentation with pleasure. Well, the floor is yours. Like, we are ready to listen to your presentation. Dear Alexey, dear participants of the conference, now let me start. Despite the era in which we're living, we're still responsible for our work. And now we will show the presentation, and I will focus on the prevention of drug abusers with HIV infection. This group of patients is rather challenging. But I cannot do it. I'll ask you to move the slides, and now it's the responsibility of our colleagues. I'll try to be brief. Still, the HIV infection is a somatic disease which threatens the physical existence. And for drug abusers, it's a psychogenic and stress factor causing various personal reactions which testify to the disease. And we need a sustainable link. We see the sustainable link between the drug use and the person's condition. And this link was marked from the outset in HIV infection management. The most comprehensive studies carried out by European scientists and Russian scientists show that there is a high level of drug use in the HIV-infected patients, which negatively impacts the ARVT. In 2018, over 50,000 new HIV cases were registered in Russia. They are part of the vicious circle. Unless they refer to the centers, they cannot get any medical assistance. And some of them do not follow the the treatment, and they keep using drugs. Thus, they need the full-scale treatment, which would consider this addiction. But it is impossible to comprehensively treat this somatic pathology, this somatic disease. There are some factors which positively influence the adherence, such as unwillingness to take drugs, and they may also change their lifestyles and augment the life quality. Some patients may help one another, and therefore they will be able to understand the value of the life, and they will be able to achieve new results. They also need accurate briefing and consulting and pieces of advice of the medical personnel. Some factors increase the adherence in the residents of our country. Should believe in the priority of the people who have already undergone this treatment. These information sources are of prime importance. Active involvement of equal counselors in the working process with the patients has a positive effect. The awareness of the patients of controlling ARVT also matters. Your nearest and dearest should support you, and awareness should also be raised in the medical personnel. To sum up, let me highlight that drug abusers had the following problems. The brain structures responsible for critical attitude to your condition and the motivation are affected. Thus, patients with drug addiction lack motivations and they have low adherence. Thus, our treatment should be long-term and expedient, and this will contribute to adherence. The total number of the patients who are ready to be treated in our mixed cohort and with comorbidities does not exceed 25%. After a short-term treatment, which will last for 2 weeks, we will see an annual relapse in 2 to 3% of patients. When we use the maintenance treatment for 3 months, the annual remission will be marked in 10 to 15% of cases. Next slide, please. This way would allow us to achieve the goal, and it's supporting these patients. We would like to create the conditions which would allow us to control the activities aimed at the healthy lifestyle, the course of and injections, and effectiveness and efficacy and safety are assessed at the highest confidence level, at the A1 level.
And how to apply the results of the prolonged injection naltrexone. And never before any shifts in pharmacokinetics had been registered or some side effects. we see some kind of a consistent picture. And as it has been already mentioned, HIV infected with some drug abuse is a very complex and cohort of patients, and we need to provide consultancy to the patients, and especially organizing this service of one window. With specialists, consultants, and the care workers, thus getting the competent aid. Only then the ART may be administered, thus minimizing the epidemiological base. And so interdisciplinary set of measures are to be labs at the level of hospitals, jointly done with the essential personnel and care workers. And that is the interdepartmental scheme, and with quite a number of agencies. And one of the distinguished positions are taken by the AIDS Center. And I'm not going to talk about the key goals and objectives, as it is quite clear how it all operates and who are the stakeholders here, and what are the functions, what is the motivation, what is the social support, individual programs, design, the consultancy service, information service. And thus we try together with you, dear colleagues, to streamline the smooth operation of this system. And within a year, our Center for HIV/AIDS Prevention are attended by more than 800 people, and they are provided with the pertinent medical aid. I actually wanted to give you a quotation. He's the head of Rospotrebnadzor, Mr. Popov. We have two pandemics, drug abuse and HIV infection, and geographically they are conjugated. And in a nutshell, what I wanted to tell you is that we're dealing with a very painstaking contingent of patients. And the discussion is still underway as to how to administer the special banning therapy. And let me state that in Russia, all the citizens have equal rights to get free of charge medical aid and narcological as well. And we have a special R&D center to do so, to provide the service, and also free of charge aid center. And let me emphasize that with due regard to the effective law of Russia on the treatment of various diseases using specific drugs, it is prohibited. That these are narcotic-containing drugs, and we may some tend to say that safely drug-containing on substances may be administered as well as the replacement therapy, substitution therapy, and euthanasia. And it has nothing to do with the subject matter of our discussion. And actually, medical personnel is not required. And we are talking about the replacement of one narcotics onto the other. And the social and other type of activity of the drug addict is a myth. And we are talking about the intoxication rather than treatment of our patients. And if narcotics are administered in the course of pregnancy, they become addicted to drugs. And before the birth of a child. And from the medical perspective, it's, by the way, it is interpreted as a crime. And naltrexone is one of the substances which may actively be used for that particular purpose. And Narcological Service of the department very actively cooperates with the Urban Center for AIDS. It is an unprecedented interaction in our AIDS premises, having 20 beds, and also we have plus 60 beds in another ward, and the special consultancy services are provided for HIV infected under treatment. And the R&D Narcological Center and the Urban City AIDS put forth a special program of rehabilitation with the involvement of care workers, medical staff, and psychologists. And we have the standalone outpatient programs in subculture. And that somehow presents a motivation and gives a remedial effect, and thus our mission becomes really noble, and remission by 30 or 40% could be registered. And especially it is related to the patients with ART. And it is not as simple as that, but nevertheless, we are going to communicate at this field further. And the infected patients may be treated 100%, thus avoiding various pathological effects. That's what I wanted to tell you. And thank you for your presentations. Thank you for your lectures, and we are actively discussing all these issues dedicated to narcology, to the support of our patients with the narcological profile. And unfortunately, Igor Vladimirovich Pechelin will not be able to take part. I think the report is important, but the contribution of our colleagues into that research presents some kind of a bridge. This program is called Bridge, MOST. And we organize this work with the center, with the Narcological Center, and it's a part and parcel of our effort in relation to the cohort of drug addicts. And it's an absolute merit of theirs that they manage to treat people this way and which become a part of this program and who go on administering ART therapy, and that is a comprehensive treatment for drug abuse and HIV infection. And definitely that is the contribution of our partners, our colleagues who work in this MOST Foundation and who are the organizers of this initiative. And they have NGOs to join this particular endeavor, and we are very much proud of their results. They work on a parallel basis with us on a daily basis, rendering assistance to that patients. Natalia Gennadievna Litvinova from the studio.
Good afternoon, dear colleagues. Can you hear me? Can you see the presentation? Oh, we can't see your presentation. Let me present the following topic: the role of the online monitoring system of the healthcare. The role of the online monitoring system of the Ministry of Health of the RF in combating HIV. You can see the speakers mode, but we need the demonstration mode. The demonstration mode. And once again, press this button. Press F5. Thank you. Yes, we are ready to listen to you. In accordance with the public strategy of combating the HIV infection, which has already been mentioned by Alexey, we created the register, the Federal Register of HIV. The aim of any register is monitoring of epidemiological situation in socially significant infections in the country and planning of drug dispensation. Here you can see the legal framework according to which the Federal Registers of the Federal Register of HIV and the Federal Register of TB patients were devised. It's Article 43, the Clause 43, the Federal Law 323. That is dedicated to protection of the health of the citizens. Part 2 stipulates that in order to provide medical assistance, including drug dispensation for medical use in some patients, Federal Register is effectuated according to the ruling of the government on number 426. The following rules of management of the Federal Register of Tuberculosis patients and HIV patients should be effectuated in order to solve the key functions and the key goals. And to achieve the key goals, we use the functions of the Federal Register, I mean the collection, processing and storage of data, organization of medical checkups, drug management, controlling and management of patients with HIV. Thanks to the Federal Register, we may plan medical assistance and form analytical forms and report forms. First and foremost, we may fill in the referral to laboratory examinations in the register. The data for laboratory tests for HIV infection and for antibodies to HIV infection may be included there. And PCR is used for examining the RNA level in HIV patients. When a patient comes to infectionist, the new register entries may be opened, and then they may be linked with the referral for laboratory examination. In comparison with the forms of governmental statistical reports, the methods of which allow us to form the reports for a certain date, the methodology of forming federal register rules out duplicates when we fill in the data of the patients. We may also receive the report on a certain data and for any study period. How does it actually work? Here you can see the first page of the Federal Register where we fill in the patient data. This data is unique. It cannot be repeated for any patient. We can see the insurance report as a key identifier of a personality, the key identity document, and also the passport data. Why can no duplicates emerge? As soon as we fill in the patient's passport data, the register is working, is still operating. And when we fill in the same data for another patient, the system gives us the signal, and we won't be able to repeatedly fill in the same data for another patient or for the same patient with another surname. It's not feasible. If the patient has no key identities, such as insurance report and insurance certificate and passport data, it will not be possible to refer this patient to another region. This will allow us not to copy the information. The register only includes the patients who refer to our clinic and those who go to the doctors. We also include the incidence cases in the register, I mean the data on patient organizations, the diagnosis under regular medical checkup, the data on newborn babies, and the data on mothers. If we fill in the data, it should have the data status at the primary registration of diseases, and they do not require any actualization. Here we can see the epidemiological evidence. The federal register allows us to carry out the epidemiological control online. At any time, we may track the epidemiological situation on HIV infection. Here we fill in the data on the circumstances of HIV diagnosis, transmission pathways, and contagion sources. In order to assess the epidemiological situation over changes, we have to stockpile the data. As for the Federal Register of HIV, it started operating in 2017. Over the first years, 2017, 2019, we stockpiled the data, and now we may assess the changes in the epidemiological process. Here we can see the data of regular medical checkup. The register allows us to monitor the histories of referral of the patients from one patient organization to another one. We can also see the evidence on each patient related to changes in the diagnosis, to concomitant diseases, to comorbidities, to dispense drugs. This register is personalized for the workers who are actively involved in patient work and who fill in the data about the patients in the register. At all the levels, the level of the Ministry of Health of the Russian Federation, the federal register is not personalized. One of the major functions of the register is medicinal management. The register includes the data about the personal needs, the regimen assigned for the patients is filled in the register, we can receive the data on the number of HIV patients, on the patients who are under regular medical checkup, the number of ARVT receiving patients. This allows us to apply submissions for medicinal products and calculate various trends in terms of future drug provision of our patients. It will also show us that we may effectuate the treatment control, and another key function is this kind of treatment. Here you can see the key parameters which we use while combating HIV, and they correspond to represented in this table, and the BLWH receive RVT, and this allows us to assess the efficacy of this treatment. Another important issue is related to the reports about ARVT receiving patients. We may monitor each patient and we may get the complete report in the of the situation in the Russian Federation. We may also assess the total number of patients receiving certain drugs and certain treatment regimen. Convenient. It's very convenient. Apart from epidemiological reports, this allows us to use it in decisions. And for instance, this may depend on the RVT treatment. One of the key reports is associated with the allows us to assess the fullness of for using in any region. Another interesting function of the Federal Register is assessing the retention of the patients using certain drugs. It depends on adverse events occurrence, and it is based on documented resistance. Alexey has already mentioned that many questions arise, and we'll have to solve some problems, and FRHIV allows us to amend it and to adjust it, and we receive lots of suggestions initiated by the regions with which we're working in accordance with the ruling of the Minister of Health related to the medical documentation of personal accountability of HIV patients. Fill in this data, and the form was also of HIV patients, and they will also be amended. There will be some changes in the Federal Register of HIV, and this will allow us to upload the data. We develop feasibility studies for quick reports in real time in accordance with the key analytical indicators, including IRVT coverage and its efficacy. Therefore, the Federal Register of HIV situation allows us to assess the epidemiological situation. It is an ever-changing structure, and it changes upon our needs. Thank you for your attention. We finish. Thank you very much. We finish our session. We had enough time, but unfortunately, I didn't manage to answer all the questions. There will be a few comments on treatment coverage. We have listened to Oleg Bozik's cases. The territory work was carried out with drug addicts, and there's such a large-scale cohort of drug addicts. Is it possible to achieve this proportion of coverage? In 90% of cases, Maybe it's not that possible. Sometimes we hear that we can see the coverage, but we know that over the past 3 years, no one has complained of the fact that the patients were not receiving treatment because their resources were not sufficient. We are always ready to provide this medical assistance. This issue is really challenging, thus we anticipate prolonged antiretroviral drugs. And we are now discussing it. It's the key topic for our discussions. This element of working with these patients is vital. We should expand the coverage without undermining the quality of treatment. And the National Virus-Related Association, which I have already mentioned, includes over 500 participants. There is also the International Council in this organization. This zone is fairly open. You may enter it. You may exit it. It's like Clubhouse, but even in Clubhouse you'll need some presentation. But we are ready to welcome all of you. It's related to the leading scientific centers of the world. You'll have a chance to undergo internship on certain issues in different corners of the world. We have this opportunity. There are also some publications in this domain. Today we give points for participation in our seminars. Thank you very much. Thank you, the organizers. Another example of this dialogue is cooperation is indispensable nowadays. It guarantees the success of our work. In the COVID-19 era, we've learned a lot of lessons from this pandemic. This tragedy takes place, but the virusologists became friendlier and the world is safer. Thank you very much for your attention.